Welcome to the M3 Core Clerkship series. This is your internal medicine clerkship survival guide, everything you need to know before day one. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Welcome to your internal medicine clerkship survival guide. Internal medicine is often called the mother of all clerkships, and for good reason. This is the rotation where you learn to think like a doctor. You will encounter virtually every organ system, manage complex patients with multiple comorbidities, and develop the clinical reasoning skills that form the foundation of every medical specialty. Even if you are planning to go into surgery, pediatrics, or any other field, the knowledge you gain here will follow you throughout your career. Here's a staggering fact. Roughly 50 to 60% of the USMLE Step 2 CK exam is internal medicine content. This clerkship is typically 6 to 12 weeks long and is the most content-heavy rotation you will experience in medical school. But do not be intimidated. With the right preparation and mindset, you can not only survive, but genuinely thrive on the medicine wards. Let us talk about what you should do in the week before your rotation starts. First, gear up. You need a good stethoscope. A Littman Classic 3 or Cardiology IV is the standard. Grab a pen light, a reflex hammer, and a small pocket reference like the Maxwell Quick Medical Reference. Stock your white coat pockets with pens, a notepad, and maybe a laminated card with normal lab values. Get comfortable shoes because you'll easily walk 5 or more miles a day on the wards. On the tech side, make sure you have UWorld Step 2 CK activated and ready to go. You should start doing questions on day 1. Download UpToDate on your phone if your hospital gives you access, and set up MD Calc for clinical calculators. If you use Anki, download or start building an internal medicine deck. For pre-reading, focus on the biggest hitters: heart failure, acute coronary syndromes, pneumonia, and diabetes management. Even just skimming those chapters in Step Up to Medicine will give you a head start. Now let us talk about day 1 logistics. Arrive 15 to 30 minutes early. Your first mission is to find the team room or resident workroom. Introduce yourself to the senior resident first. They are the person who runs the day-to-day operations and will be your primary point of contact. Say something like, "Hi, I am your name, one of the third-year medical students on the team this month. What can I do to be helpful?" That single question shows you are a team player. On day 1, you need to get a few essential things sorted: your patient list, EMR access and login credentials, a pager or phone number, the call schedule, and most importantly, clarify the team's expectations for you. Ask the senior resident, "How do you like presentations? How many patients should I follow?" This shows initiative and prevents misunderstandings later. Also, spend some time learning the physical layout of the hospital. Find the labs, radiology suite, pharmacy, cafeteria, call rooms, and supply closets. Knowing the geography saves you enormous time and stress. Let me break down the team hierarchy so you know who is who. At the top is the attending physician, who oversees all patient care, leads teaching rounds, and ultimately writes your final evaluation. Next may be a fellow, a subspecialty trainee who is often present on consult services and can be an incredible source of focused teaching. The senior resident, typically a PGY2 or PGY3, runs the team day to day. They're your primary supervisor, and building a good relationship with them is critical. The intern or PGY1 manages the bulk of direct patient care, placing orders, writing notes, coordinating with nurses. Work closely with your interns because they teach you the most practical, hands-on skills. You may also work alongside a sub-I or M4 student who is functioning as an acting intern. Observe how they operate because that will be your role next year. And then there is you, the M3 student. Your job is to follow 2 to 4 patients, pre-round on them every morning, present them on rounds, write notes, and learn as much as you possibly can. Here is what a typical day looks like on the medicine wards. You'll arrive between 5:30 and 6 in the morning to pre-round. This means checking your patient's overnight vitals, intake and output, telemetry if applicable, new lab results, imaging, and any overnight events documented by nursing or the night team. Then you see your patients, do a focused physical exam, ask how they are feeling, and update your subjective assessment. By 6 to 7 a.m., you should be writing or finalizing your daily SOAP notes. Around 7 to 8 a.m., the team gathers for table rounds or card rounds, quick, focused updates on each patient. Then from roughly 8 to 10 a.m., you have attending rounds, which is the centerpiece of your day. This is where you present your patients, discuss management, and where most of the formal teaching happens. After rounds, the late morning is spent on floor work, following up on orders, coordinating consults, checking imaging results, and doing procedures if the opportunity arises. Try to attend noon conference around 12 to 1 p.m. These didactic sessions count and are noticed by your evaluators. The afternoon from 1 to 3 is typically when new admissions come in, and the last couple of hours are for wrapping up notes, updating the patient list, and signing out to the night team. Study whenever you get downtime, even if it is just 10 oral questions during a quiet moment. If you are finding this helpful, please like, subscribe, and hit the notification bell so you don't miss future videos. Let me walk you through how to pre-round efficiently and give a great oral presentation, because this is where students either shine or struggle. For pre-rounding, develop a consistent system. Check vitals and I&Os first, then review new labs and imaging, read overnight nursing and intern notes, then go see the patient for a focused exam and subjective update. Update your problem list and plan before rounds. Know your key numbers: cold, creatinine, white blood cell count, potassium, lactate, hemoglobin, INR, whatever is relevant to your patient's problems. Anticipate what the attending might ask you. For oral presentations on medicine, use this framework. Start with a one-liner that includes the patient's age, sex, relevant history, and chief complaint. Then give a chronological HPI with pertinent positives and negatives. Brief relevant ROS. Past medical history, surgical history, medications, and allergies. Focus physical exam findings with vitals. Key labs and imaging, and know the trends, not just today's values. Then deliver your assessment and plan organized by problem. Each problem gets its own assessment and proposed management. Keep the entire presentation under 5 minutes for established patients and under 7 for new admissions. Practice out loud, it makes a huge difference. Now for the core medical knowledge you absolutely must have ready. These are the top 10 topics that attendings and the shelf-alike will test. Number 1. Acute coronary syndromes. Know the difference between STEMI and NSTEMI, understand troponin kinetics, recognize ECG changes, and know the treatment algorithm, dual antiplatelet therapy, heparin, and when to activate the cath lab. Number 2. Heart failure. Understand heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. Know the 4 pillars of guideline-directed medical therapy, beta blockers, ACE inhibitors or ARNIs, mineralocorticoid receptor antagonists, and SGLT2 inhibitors, and how to manage acute decompensation with diuretics. Number 3. Community-acquired pneumonia/pneumonia/. Know the CURB 65 scoring system for disposition and first-line antibiotics, amoxicillin plus a macrolide for outpatients, or a respiratory fluoroquinolone. For hospitalized patients, a beta-lactam plus macrolide. Number 4. COPD exacerbations. Treatment is bronchodilators, systemic corticosteroids, and antibiotics if there is purulent sputum. BiPAP for respiratory acidosis. Number 5. Diabetes management. Know how to adjust insulin in the hospital, the DKA protocol, fluids, insulin drip, potassium replacement, and hemoglobin A1C targets for outpatient management. Metformin remains first line for type 2 diabetes. Here are 5 more critical topics. Number 6. Acute kidney injury. Classify it as prerenal, intrinsic, or postrenal. Prerenal AKI has a fractional excretion of sodium less than 1% and responds to volume repletion. Intrinsic AKI, often from acute tubular necrosis, has a FeNA greater than 2% with muddy brown casts. Always check a post-void residual to rule out obstruction. Number 7. Cirrhosis and its complications. Know how to work up ascites using the serum ascites albumin gradient. A SAW greater than 1.1 suggests portal hypertension. Treat spontaneous bacterial peritonitis with ceftriaxone, manage variceal bleeding with octreotide and emergent endoscopy, and treat hepatic encephalopathy with lactulose and rifaximin. Number 8. DVT and pulmonary embolism. Use the Wells criteria to stratify risk, check a D-dimer for low-probability cases, and get a CT angiogram for higher probability. Treatment is anticoagulation, typically heparin bridged to a DOAC. Number 9. Electrolyte disorders. Hyponatremia is the most commonly tested. Always assess volume status first. Hypovolemic hyponatremia gets normal saline, euvolemic points to SI/DH and gets fluid restriction, and hypervolemic gets diuretics. For hyperkalemia, know the ECG changes, peaked T waves, widened QRS, and treatment. Calcium gluconate, insulin plus glucose, kiexalate, and dialysis if refractory. Number 10. Sepsis. Know the quick SOFA criteria and the Hour 1 bundle, obtain cultures, check lactate, administer broad-spectrum antibiotics, and give 30 milliliters per kilogram of crystalloid for hypotension. Target a mean arterial pressure of at least 65 with vasopressors if needed. Let me share some rapid-fire clinical pearls to prepare you for common pimping scenarios. If a patient develops new-onset atrial fibrillation with rapid ventricular response, your first move is rate control with IV metoprolol or diltiazem, then assess the CHA2DS2-VASc score for anticoagulation decisions. For an acute GI bleed, get 2 large bore IVs, send a type and cross-match, start a PPI drip, and consult GI for endoscopy. When you see a chest pain patient, get an ECG within 10 minutes and send serial troponins. Think through the life-threatening causes, a CSP, aortic dissection, tension, pneumothorax, /pneumox/, and cardiac tamponade. For hyponatremia, always assess volume status before deciding on treatment. And remember, when a patient is tiring out and failing to protect their airway, do not wait for the ABG to make the intubation decision. On the procedure side, there are several skills you should actively seek out during this rotation. You should be doing blood draws, IV placements, and arterial blood gas collections regularly. Practice on simulation first if available. Foley catheter insertion, and NG tube placement are also core medical student procedures. For more advanced procedures, look for opportunities to observe paracentesis for patients with ascites, thoracentesis for pleural effusions, lumbar punctures for meningitis workups, and central line placements. Volunteer for everything. The more repetitions you get, the more confident you become. Ask your interns to teach you one-on-one, and watch procedural videos the night before if you know something is scheduled. Let me talk about how to earn a grade evaluation versus how students commonly sink their grades. On the positive side, be early and stay engaged. Always have an assessment and plan ready for your patients. Never present without one. Read about your patient's diagnoses every night, even if it is just 20 minutes. Anticipate the next step before being asked. If your patient is getting a CT scan, know what you are looking for before the result comes back. Show genuine curiosity by asking thoughtful why questions. Follow up on pending results and close the loop. If a consult was placed, check what they recommended. Be kind to nurses, technicians, pharmacists, and all support staff. And critically, ask for feedback at the midpoint of your rotation, not just at the end. This gives you time to course correct. On the flip side, the fastest way to tank your evaluation is to disappear without telling anyone where you are going. Never say "I do not know" without adding, "but I will look it up and get back to you." Do not present a patient you have not examined that morning. Stay off your phone during rounds. Do not talk negatively about other specialties or consultants. Accept feedback graciously, even if you disagree. Attend noon conference rather than hiding to study alone. And remember the golden rule of clinical clerkships: effort and attitude matter more than knowledge. A student who works hard, is reliable, and shows genuine enthusiasm will always outperform a brilliant student who is lazy or disengaged. Finally, let us talk about the shelf exam. The internal medicine shelf is 110 questions over 2 hours and 45 minutes. It is the broadest shelf exam, covering every organ system with heavy emphasis on cardiology, pulmonary, GI, and renal. Your number one resource is UWorld Step 2 CK. It is the gold standard, and high-scoring students complete every question and read every explanation. Start doing UWorld questions on day 1 of the rotation. Aim for 20 to 40 questions per day initially, ramping up to 40 to 60 in the later weeks. Supplement with AMBOSS for their shelf-specific question bank and medical library. Use Anki daily for spaced repetition. Even 30 minutes a day adds up enormously over 8 weeks. Step Up to Medicine is a great quick reference, but do not try to read it cover to cover. In the final 2 weeks, take the NBME practice shelf exams. They are the most predictive of your actual score. Students typically score 5 to 10 points lower on practice forms than the real thing, so use them as benchmarks. Divine Intervention podcasts are phenomenal for high-yield review during your commute. The key is to start studying from day one and be consistent. 40 questions a day for 8 weeks is over 2,000 questions. That level of practice makes a tremendous difference. Here is your quick summary. Before the rotation, get your stethoscope, set up UWorld and Anki, and pre-read on CHF, CS, pneumonia, and diabetes. On the wards, arrive early, pre-round systematically, present concisely using the one-liner to problem-based ANP format, and study during every free moment. Know the top 10 diagnoses: cold, CS, CHF, community-acquired, pneumonia, /pneumonia/COPD, diabetes and DKA, AKI, cirrhosis, DVT and P, electrolyte disorders, and sepsis. Seek out procedures, be a team player, ask for feedback, and start UWorld on day one. You've got everything you need to crush this rotation. Good luck on the wards. I am rooting for you. Thanks for watching. Don't forget to like and subscribe for more medical education videos. All references cited in this guide are listed on screen. Sources include Harrison's Principles of Internal Medicine 22nd edition, the 2022 AHCC Heart Failure Guidelines, Gold 2024 COPD Guidelines, ATSIDSA Community Acquired Pneumonia /pneumonia/ Guidelines, KDIGO Acute Kidney Injury Guidelines, Surviving Sepsis Campaign 2021 Guidelines, and the NBME Internal Medicine Subject Exam Content Outline.